Good afternoon, ladies and gentlemen. It's my great pleasure to welcome you to the webinar organized by the European Reference Kidney Network, coordinated by Professor Franz Schäfer from Heidelberg, Germany. The topic of today is transition in nephrology, which will be presented by Dr. Lars Pape from Hannover, Germany. My name is Elena Levchenko. I'm a pediatric nephrologist from Belgium, and I will moderate this webinar from my office in Leuven, Belgium. During the webinar, the slides will be projected on your screen, and you will be able to send us your questions using the special tab on your attendee panel. Please don't be shy and send your questions. They can be sent anytime during the presentation and will be answered at the end of the webinar. The webinar will be recorded and the slides will be published on the website of the ERKNet. Let me now introduce the speaker of today, Lars Pape, who is a pediatric nephrologist with a full professorship in pediatric nephrology in Hannover, Germany. He is a deputy director of the Department of Pediatric Liver, Kidney and Metabolic Diseases of Hannover Medical School, as well as head of the KFH Center for Nephrology. His main research focus is the development and establishment of biomarkers in pediatric nephrology, as well as health services research mainly in transitional medicine and improvement of care after kidney transplantation. He is a council member of the International Pediatric Transplantation Society and director of studies of the German Pediatric Nephrology Association, as well as deputy chairman of the Task Force Kidney Transplantation in the German Pediatric Nephrology Society, and the National Pediatric Health System Advisor for Dialysis. Dr. Lars Pape is editor-in-chief of Transition Medicine, and so today he will give us a lecture about the topic he is really very much involved in. So, Lars, that was my introduction, and now the floor is yours, and we are really eager to hear your talk. Thank you very much.
Elena, thank you very much for the kind introduction. I've decided to speak on a transition because not only it's a subject of my interest despite lab research, but also because I lead the task force Transition and Quality of Life in ERKNet, and so this is one point we want to take care in ERKNet above all the different disease panels we have, and I'll come to the question, what does ERKNet do for transition at the end of my talk. But just generally spoken, what is transition? And what we face is that if you look on the left side, you see the small child, the mother taking care of this infant, and this small child which needs to be taken care of will someday just become older and then might turn into the monster that you see on the right side. And this process is something that has really an impact on our medical care. And more or less the first publication that has looked on that problem was by Alan Watson now 19 years ago, who saw that there were unexpected graft losses 6, 7, 8, 9, 10 months after the patient was transferred from pediatric into adult care, and you can just see the increasing serum creatinine in these patients. And if you look on more actual data, you can see that in no other period in life than between the age of 17 and 25, so many organs are lost because of non-adherence. Even if you look from old-to-old transplant program in people being 70 years or older, no, not so many grafts get lost as in this transition age. And why is that so? And this is because transition is a very complicated subject, and a lot of factors play a role in transition we have somehow to address. First and maybe most important point is non-adherence. Patients are not taking the medications as we prescribe them. And if you become 16 years old, many things in your life are much more important than taking medications, and you might even not want to let your peers become aware that you have a chronic disease and need to take medication. So non-adherence is a very important point in transition. We have a lot of mentally retarded patients where transition is much more difficult. We often prepare our patients not very good for the transfer. We have not only to integrate the patients, but also the parents, the families in the transition process. And I'll show you later on how. What is the real best time point of transfer? Is it really 18 years? Has it to be individualized? How is psychosocial care organized after transfer? Most often adult nephrologists have no psychologists, no social nurses taking care of the patients. The patients have to be educated about their disease, transplantation, other kidney diseases, and have to learn what to do. The information exchange between us and between university centers and between the then adult nephrologists taking care of the patients is sometimes a real challenge. Sometimes it's well organized. Treatment strategies differ between pediatrics and adults, and many of our patients have really a lack of independence. And just to focus on the, at least in my eyes, most important point on adherence, this, which is just one aspect in transition, again, has a lot of sub-aspects. We need a patient for adherence, but it's not only the patient just obeying the orders of the physician. And the patient is composed not only of spirit, but also of soul and body aspects that also go into adherence. With the disease, it's much more easy to be adherent if the disease is easy to cope with, as if you have a very severe disease with a difficult course. It's the environment. We have a lot of patients with social problems, with difficulty in their families, with difficulties in school, and others who have a very good number of friends. So depending on the environment, adherence can be made easy or can be made difficult. Then it's the therapy itself. How long do I have to take it? Are there side effects? How complex is it? And only an easy therapy with a few number of side effects is follows good adherence. And if you have a complicated therapy with a lot of side effects, then adherence is worse. And the last point is the health system. Is the medication really available that you have? Does the health insurance pay? How is it between internist and pediatrician in the health system? Are other therapists who might help you? In all these aspects, we have to address to increase adherence during the transition period. How is transition performed? The classical way is directly transfer from the pediatric nephrologist to the adult nephrologist. You can put in a transition clinic or even an adolescent and a young adult clinic, as in some UK centers, or there's some other examples like cystic fibrosis centers or centers for adults with inborn heart diseases that work in a different way. And this depends really on how our health system works and what we can do locally. This is a study that we published 5 or 6 years ago, where we looked for patients that went in a transition clinic with a specialized adult nephrologist, in an adult transplant clinic in our center, or to an office nephrologist without any university affiliation. And what we saw in the study is that all patients were fortunately quite satisfied with pediatric care. Half of them said we were well prepared for transfer to adult health care. And as we traditionally in Hannover do a lot for transition, there's a little bit sad result. Then did the transfer mean a large change of your life? And you can see that those patients who went to our special transition clinic said, okay, there's again a physician really taking care of us. It's like in pediatrics. So they said not a big change. And those who went to the outpatient unit in the university hospital, where very often physicians change, had the most impact on their life, and the office nephrologists were in between. But at least all were more or less satisfied with the care. Again, the best was a transition clinic. But on the other side, those who went primarily to the university clinic with least support said, okay, that really helped in our self-confidence. But that's just a local result. And within the ESPN, we looked in a survey, how is transition performed in all of our European centers. And this is a quite complex table, but if you look at the right side, there are a lot of tools that should be used in transition as posed by the ERKNet consensus statement for transition. You can see that some of these tools are used in many centers. So most centers say, yes, we have a kind of unwritten transition concept. We know about transition, but if you really look for training courses, for definite age, for group training courses, it's just a third of the centers, and there are many tools like monitoring progress of self-management skill, patient passport, readiness to transfer, to determine that by a readiness scale. It's only a few centers using it, so there's a lot of things we can just do. And where do the patients go? You can see that 12 of those 15 European centers, as I said, we make shared consultation between pediatrics and adults, 2 have a young adult clinic, 5 do alternating consultations. And if you look for when is the concept of transition induced, we do it normally a little bit late, 16 to 18 years. Fortunately, some other centers, a lot of centers do it even before, but others really do it after 18 years of life. And the main transfer age is 18 to 19 years, and this has something to do also with the health systems, because, for example, in Germany, pediatric nutritionists are most often just paid in patients who are below 18 years of age and are not allowed to see patients afterwards. But on the other hand, most physicians rate the age most appropriate older. They say many of our patients are ready for transition above 18 or even above 19 to 21 years of age, and this is a discrepancy which has to be solved. And again, I don't want to go in detail in these Likert scales, but what you can see is that table 3, yes, pediatric nephrologists and adult nephrologists are obviously involved in transition, and in pediatrics it's also psychologists and a social worker, but we don't really have that in adult medicine, and other professionals we need in transition, like youth workers, nutritionists, nursing staff, are only involved in some centers. And you can see that most centers, on the other hand, table 4 say, yes, we individualize our transition. Yes, we agree about transition, and we don't transfer patients in periods of crisis, which is quite nice. On the other hand, no, it's not in all centers. After school education is finished, and not all really take other subspecialties in the transition process. So many things go, but there are really some things that should be improved. And this is also something which is quite interesting. We look for the adherence score of transition with the guidelines of the ERKNet, and looked for the gross national income. And you can see there's a clear correlation that those countries with a higher gross national income have a better adherence to transition. So it is a question of money to make transition better. On the other hand, you can also see that there are countries with a low gross national income and good adherence score to the guidelines, and on the other way around, there's some countries with, like the one with $60 US or $1,000 in capita and an adherence score of 3. So variety. So money is important, but it's not all. And if you look at these 3 points with the very rich countries, which is Switzerland and Norway, they do both. They do good transition, and they have enough money to do that. What we also did is, that the next point is, where is transition really done very well? And I think Paul Harden, as a real transition specialist, has published this publication. We've also directly visited him and looked at that. he's a very good transition program as an adult nephrologist, where he sees pediatric patients after they become 18 in a very specialized transition clinic, and they don't do it in the hospital, they do it in the sports center. And while most, this example, patients are playing billiard, one is just getting into the room to Paul Harden and get some extra consultation. And by this events that are carried out 4 times a year, the patients really follow, and his special system with his specialized young adult clinic really led to no graft loss. This as compared to historic controls from his own center in Oxford and a standard adult clinic where a lot of grafts got lost before. Obviously, this program cannot be directly transferred to every center because it's expensive, and you really need some very dedicated people who are really willing to set up a program like this by Paul Harden, but it shows you what is possible if you can. Another example is the transition program, which is somehow associated with Paul Harden from Great Ormond Street, and there are 2 slides. Stephen Marks provided, and this transition program also led to very good patient and graft survival after transition, much better in literature if you really take care of the program. A third example I want to show you is the transition program Good to Go from Sick Kids in Toronto. This is a transition program not only for pediatric kidney transplantation or nephrology, but for all diseases. And the very important point in this program is this shared management program model. And what you can see is as older the patients get and as more time with a chronic disease goes on, as more you have to transfer the responsibility from the provider of the family to the patient. And the patient in the beginning who receives care, in the end becomes his own supervisor. And the family who provides care finally just becomes the consultant. And this is, I think, a kind of model you really have to take into account if you design your own transition program. And in Toronto, they also use some very good transition tools that we also try to implement in Europe, the transition scale, where a professional looks how ready is the patient for transition, a readiness questionnaire for the patient, and a nephrology medical passport that has all important information. And this would be in future the way to go, that we don't transfer at a fixed age, but that we transfer the patient when he is rated to be ready for transition. Also in Germany, we have one transition program that is also financed by the KFH. That's something Elena just mentioned. The KFH is a charity organization in Germany that organizes most of the pediatric dialysis centers in Germany associated with the university hospitals. And they have started more than 10 years ago with a program called Finally Adult, where patients go for 1 week to seminars where they learn a lot of their disease, where they increase their self-confidence, where they get to know peers. Then afterwards they have workshops, for example, on sexuality or on how to get the right job or whatever. There are weekend workshops for parents included, pediatric dialysis workshops, and there's an internet forum communication on the homepage of the program, and that works very well for more than 10 years. And also here, sorry for some German words in the slide, but I couldn't change that to English. You can see that the health-related quality of life is very high, nearly like the normal population in those children who took part in this educational program. And again, you can also see that as in the UK programs that I showed you, the graft survival is much better in this program as compared to standard kidneys, but you have to take into account that those most problematic patients we have, who have language problems, who are in difficult situations, tend not to take part in that program. So in a way, we also have a little bit positive selection of those patients who are really willing to take part in that program. What we also have in Germany is the Berlin Transition Program that is also paid for by most of the health insurance companies, and it's a very simple, small transition program, but at least it works, and we are just doing a randomized controlled trial I'll show you later on to evaluate whether this program is really good in pediatric kidney transplantation. And there's one transition interview 1 year before transfer. In transfer, structured epicrisis is written in the year after transfer. There's a second transition interview and then a closure interview, and there's case management in Berlin, which by telephone or via WhatsApp, a similar app as WhatsApp, which is more secure, does directly contact the patient and organizes all things they need, and they can contact them concerning any problems. Now I'll show you shortly this TransNephro trial we are just doing, and we will just finish putting in patients at the end of this month, and we have now more than 100 patients in this trial. And I'll give you some results we've published of the first phases of the trial. In the first phase of the trial, before the randomized phase, we also wanted to look how is transition in Germany and what is, for example, the staffing of our pediatric nephrology units. And you see it's okay, but not too good. 2 physicians, 3.2 nurses, and a half-person psychosocial team. Obviously, it's mean, and we have small and larger units, but that's what we have. And you can see, again, the same effect as I showed you in Europe. The actual transfer rate is most often 18 years, but more physicians think transfer should take place later on. In Germany, we transfer 40% directly in a nephrologist in his office, and only 25% stay in the university hospital, 21% go in KFH patients, and even some go to general practitioners or are not known. And we have looked, how is the adherence? We've looked for, evaluated that by draft levels of the main immunosuppressant, mainly tacrolimus or cyclosporin A. And there are some papers who say when who have defined when adherence is good or not. Unfortunately, we had only 5 patients in the bad category, 39 in the medium, and 75 in the good category. Interestingly, the BASICAL study has been performed in the Bronx in New York, and they have more than half patients in medium and bad and only a few in good. So we are better, but obviously not good enough. We have also done a lot of interviews in this extra qualitative study, asking directly internal doctors, pediatricians, psychosocial workers, what are, in your opinion, the main challenges in transitional structures? And again, it's a very busy table, but just to summarize this table, we've seen that, at least in Germany, professionals working with pediatric nephrology are very well aware about the importance, and the key elements are very well understood and agreed on, but it seems to be very challenged really to implement these elements in routine care. And this is the randomized trial on transition we are just performing with an interventional control group of patients 1 year before transfer, and we include them in the TransNephro trial, and half of the patients gets the Berlin Transition program and gets this app where they can communicate with the Berlin Transition program and where they can do a lot of documentations concerning their kidney. Then we have different psychosocial questionnaires as PET-Square, and then we look 1 year after the transfer again with a primary goal and endpoint whether there are differences in the draft levels of the immunosuppressant, but secondary also we wanted to know how many rejections do take place, how is graft survival, how is graft function in those who have the transition program and in those who don't have it. These are all not the primary endpoint because it's very difficult with 100 or 120 patients really to reach these hard endpoints, but at least we think that our surrogate parameter, looking at the coefficients of variation of the immunosuppressive levels, is also a quite valid goal we have in this trial. And as I told you, we just now finished including patients, and therefore in the beginning of 21 we'll then have the results, because then the last patients are 1 year after transfer. And finally, what do we do actually in ERKNet? We have this task force of transition and quality of life, and we have set our goals that we really want to look at the challenges and concepts for structured transition of patients with rare kidney disease. We have just made, and many of you took part, a survey on current transition practice in ERKNet with some preliminary results that are quite similar to those results of the ESPN I've just shown you. And we have just now written the manuscript and submitted that. We also want to look more deeply, and that's something we have not yet done, on the financing of transition in the different European countries who are taking part in ERKNet. And we want in the future to look on patient expectations and experiences. We want to make a survey on parents' expectations and experiences for transition, and also we want to get better ideas how the adult nephrologists really feel about transition. And this is something we experience very often when we go to nephrology congresses. And there is a symposium for transition. You most often just see a few pediatricians there, but most often not the adult nephrologists, because for most of them it's very rare to have a patient who's transferred with a kidney disease, so it's not their main focus on a congress to inform themselves about transition. And within the ERKNet registry, we are just starting now to implement the PETS-QL as the main questionnaire for looking at quality of life. What we do in addition to looking for transition for adults, the KDQL, kidney disease quality of life measure, which is based on the well-known SF36. And also we want to implement a strengths and difficulties questionnaire to assess social adjustment, and we do all that in close cooperation with the CLIC program in the Netherlands. Antonia Bouts, they use more or less the same questionnaires, so that we can really harmonize that within Europe for kidney diseases, hopefully. Okay, so we try to do all that so that the jump from pediatric to adult nephrology will hopefully really be successful after transplantation or with any other chronic kidney disease. Okay, before we come to your questions, I have 3 not too difficult questions in transition to look at, and I'll start with the first one, if I manage that. So hopefully you'll see it and can answer it.
I think we can see it, so people can vote, I guess.
Ah, yes, I get an answer.
Okay.
So I don't know whether we can post the answer, but more or less it's very easy. It's all transition tools I have shown you. Actually, 60% say yes, we need a transition readiness scale. I would think it's, oh, that's the result. I would say this should become 100%. Nephrology medical passport might be important, but there are other ways. And I think what will happen is that we have just a health app where this information will be included. Patient education, more or less everybody agrees on. Family integration, I think also it's very important, but it's just 74%. And structures, epicrisis mainly means a kind of doctor's letter, which includes the whole history of the patient. That's always very difficult to write, and you might take some hours, but at least in my opinion, it's also very important if you're 18 years old that you have a really very detailed letter about everything, what had happened in pediatric nephrology care, what you just might need in 5 years, in 10 years, or whenever. Okay, then we come to the second question. When should transfer be performed?
Okay, please vote.
Okay. Okay.
Can we see the screen with the results?
Oh, okay. So this is a quite typical answer. 50% say based on the individual situation, and 33% say at the age of 18 years. If you look at the literature, nearly everybody says based on the individual situation is the right answer. But the contra-argument that many physicians, and here it's a third of those taking part today, say no, we need a fixed age. And if we know that it happens at 18 years, then we know when we have to compare how to prepare the patient, we know when he goes. Because if we base it on the individual situation, we have a never-ending story of many patients after half a year, after 1 year again asking, oh, can we prolong pediatric time for the next 6 months? When is the right time? And it's not too easy to find the right time point, but I think it's quite interesting that it's only half of you really saying based on the individual situation and the others giving fixed ages. Okay, and the third one is what is wrong? Okay. The question is what is wrong, not what is right. Okay, now I can do it even myself. So the gross national income is obviously right, I showed you. Adherence is obviously right because the medical outcome is influenced by adherence. Gender was 35%. I did not show you any data about that. There are a small number of papers saying there might be a gender influence, but if you look on all the larger analyses, it's not a gender difference. So we all would maybe suspect that young male adults are even less adherence and because they accept more risk or whatever than females, but it's not right. All the analyses show no, or the large analyses at least show no difference between the two genders in success of transition, and obviously improvement of patient self-management skills is very important to reach a good adherence and thereby a good transition. Okay, so thank you for listening. I hope I did not speak too fast. And then Elena can moderate the questions.
Thank you very much, Lars, for a very nice lecture. I think you gave a full overview about the subject. I just kindly ask the audience not to be shy and send me your questions. Maybe I can start with a few questions, comments. So, as we have seen, a lot of people told that the transition should be based, or the age of transition should be based on the individual situation. However, in many countries, this age is really defined by the rules of the hospital or even at the national level. For example, in our hospital, we have to perform the transition by the age of 19. And in many countries, this age is even 16 or earlier or later. So how you suggest to deal with this, legal issues? Some patients, we really feel they're not ready yet, but on the other hand, we have to transfer them to the adult services.
It's the same problem we have. I've also to transfer the patients in the age of 18 in my situation in Hannover. And we really try to work politically. So we have a German Society of Transition Medicine where people from different diseases are actively working, and we really try to go to physicians, we go to physician councils, we go to the Secretary of Health, and we really try to fight politically that our health system will in the future allow also later transfer for patients with defined criteria, but it's a very difficult process, and that has mainly something to do, I think, with the fact that pediatric care is more expensive, and that most, or many, not most, but many of the adult physicians do not really see that this is an important point to deal with.
Yeah, I agree. It's not very easy. And in your center, do you have a kind of transition coordinator who coordinates different people involved in this process?
Yeah, actually, we have a nurse who is really taking care of that. But that is really a problem that many centers have. You need a really, the literature calls it a transition champion. Every center needs a transition champion, a person who is really interested and dedicated in doing transition. In our center, this is more easy because we also do studies on transition. So it's a daily project we have, but I know it's very difficult for many centers just to define such a transition champion, a person who has really the time and is really willing to take care of that.
Yeah, thank you very much. So in the meantime, we have a question, which is apart from the practical transition, isn't it important to prepare patients and families for transition, see body review program growing up ready? So I think you mentioned this program.
That's absolutely important. This seems to be, as it's Holland Blue, seems to be not a German program, but we also have a program which is finally adult, which is probably similar to Growing Up Ready, and that is absolutely important to have that kind of education. And there in Germany we have the positive situation that we have a more or less national education program, at least for chronic kidney disease and for transplantation of other diseases. But I know that many countries or health systems do not have such a program. It's very difficult if you want to implement such a program locally.
Yeah. So apparently in the Netherlands there is a website. So the person asking the question is giving the link to the website. So it seems very nice to look at. Yeah. Okay, so I don't have any other questions. So I ask the audience, it's your last chance to ask the questions. If not, I would like to ask Tanya to close the webinar, and I would like to thank Lars Pape for his excellent talk and the audience for your attendance. Thank you very much. The webinar is closed.
Thank you.
Bye-bye.
Bye.